Guys, good morning. Who's so I'm gonna during this, you guys know I like to ask questions and things like that. So um feel free to pipe in and interrupt me and or answer questions. Um Silence is deafening, so by all means, please chime in. So we're going to talk about the Emergent Airway. I quickly realized that this title page is definitely need to be updated. These logos are all old. But anyway, so we're gonna jump right into it. So, you know, airway is something that terrifies all of us in general. Even myself as a seasoned ER doc, I think being on the sidelines and having an airway issue still would make me a little bit nervous. But that said, I think we can kind of talk through it and we can go over some basic maneuvers that are really going to kind of help quite a bit in the scenario. So we're just going to jump right into it. So hopefully you guys have your screens on. So worst case scenario, because I like to give worst case scenarios. So you're covering a high school football game. Linebacker goes to make a tackle, lowers his head when tackling the running back. Suddenly he drops to the ground and is motionless. What do you do? This is when you guys can chime in.
Make sure he's breathing.
Okay. So, we're going to run out there. All right. So players moving, not breathing. What now?
Is he supine or prone?
We'll say he's supine.
You already gave a hint to it, but in the ED we do A, B, C, D.
There we
Airway,
go.
airway, breathing, circulation.
Exactly. We'll jump right into the ATLS primary survey. I know this is not complete, but this is just giving you an idea of where we go. So remember, airway, 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 right? So in the setting of trauma, one of the quick killers is a air loss of an airway. Okay, so in this situation, yes, we need to maintain C-spine. Yes, we need to worry about the brain, all that, and the neck. But without an airway, none of it matters. Okay. So in the ATLS primary survey, the first thing is A for airway. Okay. I did put this arrow here because, depending on what literature, where we are with things, A, B, C, C, A, B, when you're going out to evaluate a player, you're going to be kind of checking the airway and the circulation at the same time. So, you're going to check the pulse, you're going to listen to the airway, you're going to check to see if there's gurgling, check to see if there's air movement, things like that. Okay. So just know you can kind of do that in concert, but A means airway. Okay. Super important. Okay. So you get out there, the trainer stabilizes the C-spine. He has a pulse. Oh my goodness, thank goodness. But there's no airway. So what now? We manage that airway. Okay. So the first thing you want to do in any emergent situation is breathe in and breathe out and check your own pulse, check your own airway. Because the last thing you want to do is panic and then kind of get jittery, jump all over the place, makes everyone anxious, and then you're getting nowhere fast. Okay. So just take a second, think about it, taking a couple extra seconds to get your thought process straight will save you in the long run. Okay. So this is a little algorithm that I found online years ago. This is just like a basic airway management algorithm. Okay. So we're going to run through it. All right. So first, you're going to assess the airway. Do they assess the patient? Do they need airway? Do they need respiratory? Pre-oxygenate, prepare equipment, call for backup if anticipated difficult airway. Assume every airway out on a sideline or on a game or anywhere is difficult. Every airway I approach in the emergency department is difficult. I never assume an easy airway ever, ever, ever. I'm always thinking about 20 steps down the line, what I'm going to do when every step fails. Okay, so just anticipate that. We always hope for the best, prepare for the worst. Just assume things are not going to go well. So start mobilizing everything. Okay. So in general, this is what you're going to have on a college sideline, on a professional sideline, kind of all these things. At Duke, this is what we had when I was a fellow. Like anywhere you went, this thing went with you. It was awesome. That's not what we're going to have on the high school sidelines. The vast majority of us are on the high school sideline, not on professional sidelines. So in general, this is kind of the setup you're going to have basically. Okay. So I would encourage you guys to consider these things. In my medical bag, I have all of this stuff. Okay. Again, prepare for the worst. So does anybody know what these things are?
Like suction?
Yeah. So this is portable suction. So traditionally, like in the hospital, we always have like that mechanical suction and all that kind of stuff. But on the sidelines, this is what you're going to have. And most trainers do carry this. Most trainers I've talked to, they carry this in their general medical bag. I don't carry this in my bag, but most of them don't have these devices. And these can be wildly important because even a little bit of secretions can totally occlude an airway. Okay. So anytime I'm beginning the season, when I'm talking to the trainer, I like to see if they have these. And most of them do. I haven't found any that don't have one of these devices actually. Okay. So what about what happens? You get out there and they got this. What the hell do you do with this, right? So what's important here is always remember the tools. So before every game I cover, I always talk to the trainer. The trainer's usually pretty good about this. Make sure the equipment and tools are available. With the Browns, with Duke, like they had there was a player down, equipment manager also went out to the field. That way they can, if there's any like all call, like the equipment team was out there, so they can remove things really fast. They have all these tools. But on the sidelines, you just want to make sure that you and your trainer have these things and or at least know where you can get to them quick. Okay. Because the last thing you want to do is try and manage an airway through a face mask like that. So, prior to any transport, this is what we practice and what we teach prior to any transport anywhere, any kind of boarding, any kind of potentially unstable player, the face mask comes off. Okay. We got to get that face mask off. That way we can assess that airway. And then we do basic airway maneuvers. Okay. So what do we think about this one? You get there, there's gurgling, you need to open the airway. What do you think about the head to head in this situation with this player in a traumatic situation? What do you think? What are your thoughts about the head tilt chin lift? Is it good? Is it bad?
It's not good if you're concerned about a C-spine injury.
Yeah, pretty bad. So don't do that. Okay. We assume any of these things, like especially these collision sports, you assume an injured C-spine, so you assume some instability. So just always protect that. However, what you can do is just a simple jaw thrust. Okay. I teach the trainers, and in the ER, like a simple jaw thrust helps you out 90% of the time. Someone's totally unconscious, they take a big head injury, they lose that airway. Just simply lifting that jaw up, stabilizing the side of the head, and then lifting that jaw up is going to remove a lot of obstructions. Okay. And this is crazy helpful. So just be comfortable knowing how to do a simple jaw thrust. It's real easy, gonna save you a lot. Okay. And then you begin back. So you open that jaw, you open that jaw sometimes, or hopefully they start spontaneously breathing. If not, you got to give them a little back support. Okay. What do you do next? Joseph, you're not allowed to answer. You've been answering all of them.
Somebody call the ambulance yet?
I think that's a good idea. Anyone else?
If they're still not spontaneously breathing, are we able to put an LMA in or something that's going to give us just a little bit more of a controlled airway?
Yep, there you go. So we're going to listen, see if there's movement, insert an airway. And you're right, Dr. Briskin, get them the hell out of there. However, prior to doing that, because it's going to be really tough, like you're calling EMS, it's going to be really tough to hold that airway the whole time. So we're going to talk about basic airway devices. Okay. So I put these, so there's 3 basic airway devices that we use in the pre-hospital setting. You got your nasopharyngeal airway, otherwise known as your NPA, your oropharyngeal airway, otherwise known as your OPA, and then your extraglottic device. I want everyone to be very comfortable with the NPAs and OPAs. Extraglottic device, that's a little bit higher level, but we still should feel pretty comfortable doing that. Okay. So your NPA, your nasopharyngeal airway, or NPA, is just this simple tube that literally goes into the nasopharynx. It's great. This thing, easy, it's simple. The advantages are it's easy to size, easy to use. And if you look in this picture here, it separates the tongue from the nasopharyngeal wall. Again, this will help with a lot of your obstructions. Disadvantages, it can initiate a gag reflex, but not commonly. Any contraindication is trauma or deformity to the midface, because then you don't know, you may be throwing that thing in there, it may go upwards and it may go to places that you don't want it to. So if there's any like facial midface trauma, this is not an option for you. Okay. So this is how you size it, from the side of the nose to the side of the ear to the tragus of the ear. But like the mid-size universal, it fits pretty much anybody. Okay. So what's important in this one, I know there's a lot of words and a lot of pictures here, but simply you just take it, you kind of place it upwards, you look to see which nair is larger, and then you go in there, you put it in, and then you spin it 180 degrees and it slides down. Something that's really important that I want everyone to know about is use lubrication. Okay. You know, if they have a bloody nose, you have to be a little bit careful with that because then you're worried about any kind of mid-face trauma. However, or snot's fine, but a lot of times I always like to make sure we have lubrication in the bag because last thing you want to do is try to jam one of these things in there. It's getting caught and you're causing damage to the turbinates. Okay, so you want to use lubrication, slide it, flip it 180 degrees, and that usually has it slide right down into place. Okay, so with that, I'm going to take a break here real quick, and we're going to watch a video. I love this video for a couple of reasons. Bear with me 1 second. Can you guys see this video screen? Or is it still on the PowerPoint?
PowerPoint.
Okay. I know you can call me a boomer. There we go. How about now? You guys see the video?
We're good.
All right, see the YouTube. Okay, perfect. Here we go. So the best part of this is they use a soldier because soldiers can't say no. You guys hear volume here?
No.
Oh, I hate this. I hate Zoom so much. Okay, whatever. I'll just kind of describe it as we go here. So basically what they're doing is they're showing you the tip of the, so remember that bevel part or that angle part, aim that towards the septum. So they're putting lubricant on here, super important. So something to note, this guy's totally awake, okay? So they're gonna insert it, aiming up, they're aiming it towards the back of the head, and they put in, they're gonna spin it. Got still awake. So that gives you an idea of how well this is tolerated, especially an unconscious patient. This is real simple to do, okay? And only military would be able to do that. I love it. Okay, so let me go back to my PowerPoint here. Is the PowerPoint back up now?
Yep, we're good.
Sweet. Okay, good. So, and this is what it looks like. You insert this thing, goes in there, opens up that nasopharynx. This is going to help you a ton. Real easy, real fast, real simple. Okay. The next thing, any questions about the NPA? Okay, I'll take silence as a no. So next, we're going to talk about the OPA or the oropharyngeal airway. Okay. Also a pretty easy device to use. The advantages, easy to use, easy to size. This separates the tongue from the nasopharyngeal wall, so it sits a little further down. Larger, more direct, and in all honesty, easier to put in than the NPA. The disadvantage one is this will absolutely cause a gag reflex. If your patient is at all awake, this will not work for you. So it's very uncomfortable. It goes way back in the oropharynx. So they will absolutely fight you if they're awake, which is good because then they'll kind of open their airway at that point. But just know this is for the absolute obtunded patient. Okay. Contraindications on this one: trauma or deformity to the jaw or lower face. Because if you can imagine, you have a big jaw fracture, or you have any trauma here, inserting that thing can be problematic. One, because you don't know where you're going. Two, you may go to some bad places. And three, if it's full of blood and things like that, you're not going to be able to do much with that anyway. Okay. So any jaw trauma, this is not your option. Okay. Again, this one, the way you size the midpoint of the incisors, the angle of the mandible. Again, you have like the mid-size, which works for just about everybody. Really important here is to have this tongue blade, because sometimes as you try and insert this thing, if it gets on the tongue, it just kind of keeps jamming back there and doesn't get free. So you need to take something to kind of pull that tongue out of the way and then drop it in. Okay. In general, for this one, I also recommend if when you enter it or when you put it in the mouth, you aim the sublunar part kind of towards the head. Again, because as you go in there and then you flip it, and then it flips into the correct position, and it kind of pushes that tongue out of the way as well. So that makes it real easy. You always aim it upwards as if you're going towards the brain, and then you flip it 180 degrees as you go in. Okay. Comparing the NPA and the OPA, this is what they look like. Okay. And this is just a picture comparing where they sit. They both kind of do very similar things. Except the OPA is definitely a little bit more effective in pulling that tongue off the back of the wall, whereas the NPA kind of opens the nasopharynx, the OPA opens the oropharynx, okay? Just know your OPA is a lot more uncomfortable. And you can do that. Like I like this picture, like you can literally just have an OPA, NPAs, like you can have all these things intact, okay? And you can put them all, they're gonna hold the airway open. However, just be very mindful if you're using OPA, if they're awake, they will vomit, they will occlude their airway, it will be a total disaster, okay? So you got the airway in, what now?
We need to confirm that we're appropriately ventilating, so listening for equal breath sounds.
Yep.
If we
you've done
have
that.
oxygenation monitoring, and
Yep.
then is the ambulance here?
Get them the hell out of there. Yes, you're absolutely right. This is a lot. This is enough to save a lot of situations. Okay, you put an MPA in, you put an OPA in, give them the air, make sure their airway's open, and then get them the hell out of there. Just know that these are not permanent airways; these are temporary adjuncts. However, once EMS is there, once they have them in the rig, they can do more definitive airway maneuvers. Okay. All right, so let's talk about things are really not going well. Okay, so you're trying to do this stuff, it's not working, What now? So, you got to reassess the patient. You have your equipment, you got your airway in. Next, and you're doing these things, it's still not working. Okay, again, don't panic. This is our job. Do not panic. You panic, it all goes downhill. Okay, so you really got to take a breath in, take a breath out, think about what is next in your toolkit. Can anyone think about what they would do in this situation? I'll give you a hint. So a lot of times, or I shouldn't say a lot of times, but sometimes you can put these airways in. And remember, like the NPA, it's a small tube, the OPA, like you open those up. But if their oropharynx is still full of secretions, like no matter what you're doing, they're not going to get airway through there. So this is a great time to just throw in that suction device and try and suction that airway. You may be surprised. You get a little spit out of there, you get a little bit of blood out of there. It opens that thing up, and then you're good to go. Okay, so just keep in mind, you still have the suction device that you can throw in there and try and get anything you can out of there in hopes to open this thing up. Okay, so you've done that. Now we're going to talk about more of your definitive or your temporarily definitive adjuncts. Okay, so let's say, I apologize here. Okay, let's say you do the OPA, you do the NPA, things aren't working. Your next go-to at this point would be an extraglottic device. Okay, certainly we can think about intubation, but we're going to talk more about that in a minute. But your extraglottic devices are saviors here. Okay, I got a picture here of a lot of different extraglottic devices where I trained. Like I saw all kinds of these weird things coming in the rigs. But the one that we're using most often is the iGel. That thing is awesome. I haven't seen, so I put a picture here because the King Airway is what they loved to use when I trained in Miami. Joseph, you can tell me, I don't know. I haven't seen one of these King Airways in a while, but I remember when I was in Miami, they all loved using them. Have you seen a King Airway for a while, or they all switched to iGels?
It was all iGels.
Awesome. Thank God. Because these King Airways are miserable. There's a lot of steps. I think at least every patient I've seen come in now, everyone's using the iGels. I feel like that's a pretty universal thing. The iGel is real simple. Okay. Advantages of this of the extraglottic device, or I'll just refer to the iGel. It's a near universal size, large and direct. There's less air to the stomach because what it does is as you insert it, it suctions to that glottis. Provides oxygen directly to the trachea. Disadvantages: can initiate a gag reflex. Again, if your patient is all awake, this is not going to work for you. Okay, they will fight, they'll bite, it'll be terrible. In which case, their airways are usually okay, so you can kind of move them on. But just this is for your obtunded patient, and nothing else is working. Contraindications: this one again, trauma deformity of the jaw or lower face, because you don't know where the hell this thing's going. Okay, these are your different sizes. Literally, size 4 can be used for just about anything. Okay, this is real simple. You take it, and this isn't one of those where you take it and you flip it. This one you just throw it in, you kind of hit the top of the hard pallet, and it just slides directly in place. Okay, I will show this video, but it's kind of a long video. But basically, it shows how the device kind of it slides across the top, and as you put it in, it literally drops right exactly on that glottis, just like you want it to, and it really causes a nice seal, or creates a nice seal that you can start ventilating the patient. Okay. So let's talk about endotracheal ablation. Or I guess before we get there, the iGel will save you in so many situations. We literally use the iGel in the emergency department to help protect an airway when everything else has failed. It is a great device. Just know it's not a permanent device. It is still a temporary device, but it will save your butt. So I would at least look at it, be comfortable with it. Most of the trainers I've worked with in the sidelines do carry this. All EMS crews will have the extraglottic device or the iGel. Okay. So now let's talk about intratracheal intubation. I love this picture. Does anyone not know this movie? And you can be honest, because it will definitely show my age. Or better yet, can anyone just tell me what movie this was from? Please. Otherwise, I'm feeling
Anchorman.
extremely. There you go. Thank you. So Anchorman, I love this. So like to do an intratracheal intubation, you got to have the whole team there. Okay. This is not something that you just like you and the trainer, you're like, oh, I got this tube, I'm going to try this. No, the answer is no, don't do that. Do your extraglottic devices, do your basic maneuvers, wait till the crew gets there. Do not try an intratracheal intubation. Okay. In fact, most EMS crews are not doing an intratracheal intubation. Okay. So more and more studies are recommending against it. It's, again, go on this page here. The extraglottic devices are first choice to bag valve mask in an unresponsive patient. The use of EGD is well over intratracheal intubation by ALS in unresponsive patients. Endotracheal intubation without rapid sequence intubation leads to a very high rate of failure. And rapid sequence intubation is, as medication, like basically sedating and putting patients down. If you try to do this without that, unless this patient's pulseless, absolutely forget it. And even with that, don't do it. Just don't do it. Okay. So don't even worry about this. So let's say you're in a situation where shit has really hit the fan. Like you go out there, like the mid face is like, let's say a player is going to make a tackle, helmet gets ripped off, gets smashed in the face, and now you have a really swollen face. You have a swollen mid face. You have obvious deformity in the lower face. What's your option now? And by the way, I hope none of you are in this situation.
A surgical airway.
Yeah, good job. Yeah, so your only option is to go below this airway directly into the trachea, right? So or into the cricoid region. So your indications: when intratracheal intubation is not possible, when other airway adjuncts are unsuccessful or not available. This is the oh shit moment. Okay. Contraindications to this are, I would really argue, none. But these are relative contraindications. Inability to identify anatomy, you just do your best, okay? Because otherwise, if you don't do it, there's nothing, okay? Children under the age of 8 don't technically have a cricothyroid membrane, and we're going to talk about what to do with them. Again, God, I hope none of us have to do that. Any wounds over the site, direct trauma, obstructing landmarks, history, cancer, radiation, surgery to site, things like that, which doesn't apply to most of our patients or most of our athletes. But again, you don't have a choice. You don't have a choice. You're going for it. Okay. So here are your tools. So believe it or not, I do carry these things in my sideline bag. I do carry it always in my military bag when I'm going out in the field. I always have this stuff, but definitely even on my sideline bags, I carry this. I like transfer my cric stuff into my med bag because you just never freaking know. This is not the moment you want to go digging for tools. Okay. This is what you're aiming for. Okay. So basically, you're going to feel that throat. You're going to feel that thyroid prominence. And then you're going to feel that little gap right underneath that Adam's apples would like to call it, that little tiny gap. That's where you're going. And I wonder how many of you are feeling your neck right now. Most of our athletes are not going to be very overweight. You should be able to feel this prominence pretty well. Trying to do a cric on someone where you don't feel that prominence really sucks. But most of our population, we're going to feel that. Okay. Basically, you just go in there, you make a little slit, you open it up, you throw the tube in. Okay. I have that cricothyroid kit, or cricothyroidotomy kit that I carry, but also like you can have like the mini kit, which is I do have a couple of these set up too, where you have a bougie, a blade, a tube, and a syringe, and that's all you need. And you should, or I could say in the emergency department, you can do 90% of your job with just these things in your pocket. Okay. And this is kind of how you do it. You make a little slit, you throw your bougie in that little slit, make sure you're in the trachea, boom, boom, done. Okay, and this is what it looks like, although this is not an athlete, obviously, or maybe it's one of our pickleballers that I see. But otherwise, this is not a common thing that you'll see. But this is kind of what it looks like if you do that. Okay, I'm going to show you guys a video from my residency. It is not pretty, but this is actually a cric that I did. I had no idea it was being recorded until after we were done. It was kind of like one of those learning crics that I did, but I happen to have a video of it, which is awesome. And this just gives you an idea of kind of what we would see. This patient is, you'll see compressions happening up here as this patient was a cardiac arrest. But you'll see kind of what this is supposed to look like. Okay. And by the way, he was like pretty much dead when we were doing this. So it's not like a bloody mess, but this gives you a really good idea of what the anatomy and everything looks like. Okay. So here we go. You guys good? do this correctly again. Do not, you have to see this now. Then you pick up on it, and completely just type it. That's what I wouldn't do this. I would definitely close that way. I wouldn't fix it. Not go like that. See, we're in the trachea. And now we're just going to throw that dude. It comes. See that? Again, this is not pretty, but it gives you an idea. Okay. Okay. I know it's not pretty, but does that give you an idea what that's going to look like? Any questions about that? And you can comment on how ugly that was. I'm fine with that. Okay, silence is deafening. I'll take it. So, the indications for needle. So in the situation where you can't do a Craig is age 8 or less. Heaven forbid, we're going to go through this real quick. None of you need to do this, okay? The indications of needle Craig, inability to perform surgical Craig, inability to use any other airway adjuncts, age 8 or less. Contraindications, like none, okay? Positive tracheal sure, whatever. Again, this is your only option. You can do this in adults, okay? Just know it's not going to give you what you want. It's not a definitive airway, but it will keep them alive until they can get one, okay? And basically, this is all you need. So for adults, a 10 to 14 gauge needle, peds 16 to 18, you pop this thing in, you get in the trachea. I like to, when you're doing this, you want to kind of pull back on the syringe underneath the skin. And so then you know, once you're in trachea, boom, you know you're hitting air. And at that point, you take that off, you have a little lure lock adapter. If you have saline stuff, sure, put it in the syringe, then you can see air bubbles, things like that. But on the sidelines, we really don't have that thing. Then you can literally hook this bag up with a little syringe, 3 millimeter syringe, boom, done. And then you can actually, believe it or not, keep them alive for a little bit, okay? So in review, these are things that I generally recommend that you have in your bag. So obviously you have your gloves, your stethoscope, ambu bag and mask. Your trainer's gonna have this. NPAs, OPAs, trainers carry this. Manual suction device, again, they carry it. I would argue you should always have a tongue blade or something of the sort. And I forgot to mention this earlier, do not stick your fingers in airways, okay? So the last thing you want to do is like be trying to pull their tongue up or trying to do something, sweeping your finger in there. They wake up, they clamp down, and you just lost a finger. Well, that sucks, okay? So I'm a big proponent of having the tongue blade so you can kind of do things, move the tongue around, stuff like that. Extraglottic device, again, most trainers carry this. Lubricant, most trainers carry this. Portable oxygen tank, everyone's supposed to carry this. And then, like, if you really want to be kind of cavalier, you can have a blade, Craig kit, all that kind of stuff. 602 or 14 or 16 angiocath needle. Again, I carry these things and mostly in hopes that I don't ever use them and I ward off the evil spirits. But having them in your bag definitely gives you that extra adjunct you may need. You know, certainly we'll probably never need that in like a professional situation. However, in high schools, when we're out like in kind of rural areas, this may be something that you want to carry because it's going to take a little bit longer to get your resources. Okay. Again, here is the general algorithm. It's a very basic algorithm. We use a totally different one in the department because we have all these other things that we can do. But for you, out on the sidelines, this is your algorithm. This is what you're going to have. Okay. And then the second you have anything definitive or even close to definitive, you get them the hell out of there because they will get their definitive airway either in the rig or even less likely the rig, but definitely once they get the emergency department, they're going to get a really good airway at that point. But they also have all the resources. You know, that's how they can do it. Whereas you on sideline by yourself, oh my goodness, you got to do your best. Okay. That said, here's my resources and I will open it up. Any questions? Okay, I'll take that deafening silence as a no. Dr. Briskin, anything else we need?
Nope, that's it. Great talk.
Perfect. Okay, guys. All right, enjoy your weekend. Enjoy your Friday. And those of you with me today, I'll see you in a few minutes. See you guys.
Thank you.